start the workshop by introducing our first speaker, so Celia Gregson, who's an orthogeriatrician from Bath, among her very many other more academic hats, an epidemiologist, and you'll be hearing from Celia on Friday as well. Thanks.
Thanks, Anthony. Hello, everybody. So 5 minutes on how we should manage vitamin D deficiency and how we should correct that if we want to get IV Zolin ASAP post-hip fracture. So I'm going to address 3 questions. 1, do we need to check vitamin D levels? 2, can correction go ahead without checking vitamin D levels? And 3, how quickly can vitamin D deficiency be corrected? So, the first thing to say is vitamin D deficiency is extremely common in the context of hip fracture. Here are 3 slightly randomly plucked publications from the literature. Whether you are in sunny Singapore, as the authors wrote, still only 8% of their population had adequate vitamin D who were coming in with hip fractures. So I think we can accept that vitamin D deficiency is really common. What's interesting is that when somebody is sick, vitamin 25-OHD levels drop very quickly. So this is a study of cardiopulmonary bypass. And the blue line is 25-OHD, and within 5 minutes of putting a patient on bypass, their 25-OHD mean drops from 60 to 40. And then it takes about 5 days for that to come back up to where it was before. So there's a very quick shift in measured 25D3. And here is an example where the authors are concluding that actually it's a little bit unreliable to measure 25-OHD3 when somebody is acutely unwell, because it is a marker of systemic inflammatory response. So here are 30 patients who had an elective hip or knee done, and you can see that within 48 hours their CRP's gone up, but also their 25-OHD has come down and their vitamin D binding globulins come down. And there's some suggestion that this might last for 3 months actually before levels have completely settled down, and that's in the elective situation. So measuring it isn't completely reliable in the context of an acute hip fracture, certainly if you're not measuring it for a couple of days after that person's come in. So how much vitamin D should we give? So this was a systematic review meta-analysis of studies that used a large single dose of vitamin D. And it included 30 studies, nearly half of them were in older people, and they gave either D2 or D3, dosing either 100,000 units or up to 600,000 units as a stat in these different studies. And many of them actually many of the higher dose supplementation studies included in this review actually had a mean baseline 25-OHD of more than 50 nanomoles per litre. So they saw that serum 25-OHD peaked between day 3 and 7, so quite soon. There seems to be a timer on this. Quite soon. And actually, in those studies where they give a slightly higher dose, 300,000 units, then the PTH was lower by day 3. And in the studies that gave D3 of more than 200,000 international units, that was essentially required in order to achieve a mean 25-OHD above 75 nanomoles per litre. And levels, or a dose of at least 300,000 units was needed to consistently suppress PTH in the studies included in this review. They found that D2 was pretty ineffective, D3 was much better, and they only saw some adverse events once you were loading more than 500,000 international units, and they were relatively mild adverse events, such as asymptomatic hypercalciuria and occasional hypercalcemia. And of course, what you're going to say is, well, you can't give a big bolus of vitamin D because it'll make people fall over. And there's been a lot of discussion about that. There was this very nice systematic review meta-analysis published just very recently, looking at the use of bolus vitamin D and looking at a series of studies with falls as the outcome. And what you can see from the forest plot is they all line up on 1, i.e. there's no increased risk of falls. Now, when you then do all of your subgroup analyses and chop up the data in all sorts of different ways, certainly more than 20 ways, then the authors found a suggestion maybe of an association with increased falls if you're giving D3 instead of D2. But this is entirely explicable by chance. And when they looked at the association with fractures, again, these studies all lined up on the forest plot at 1. And again, when you chop and change your data in many different ways, then you can find an association in those studies that recruited fewer than 1,000 people. And in those, there was an association with reduced fracture risk. And again, I think that this is more about the methods of how the study has been done necessarily than a true causal effect. So a couple of other quick points. Why do some people split the doses when they're loading somebody with vitamin D? And that's really kind of a practical thing. You know, people are nil by mouth, they vomit, they get delirious. We've all found little white tablets in the bed sheets and we don't know how long they've been there. So rather than putting all your eggs in one basket, I tend to split the dosing just so that if one tablet gets missed for whatever reason, actually overall somebody's getting an adequate loading of vitamin D. Now, so you may not measure vitamin D, and often it isn't available, and if you can't measure vitamin D, certainly do measure the calcium, because clearly you want to ensure that somebody isn't hypercalcemic before you load them with vitamin D, because if they also have a component of vitamin D deficiency and you load them, you can push somebody into malignant hypercalcemia. One thing that we do say in this consensus statement is that high-dose vitamin D may unmask previously undiagnosed primary hyperparathyroidism, and so patients who are coming in with a baseline calcium the upper end of normal ought to really have their calcium checked some weeks down the line to make sure that we haven't pushed them into a hypercalcemic state, but one would certainly not delay the administration of IV Zol for that purpose. So to answer the 3 questions, do we need to check vitamin D levels? No, not necessarily. Access to vitamin D testing isn't available to all, and routinely waiting long periods of time for vitamin D to come back, that means you miss the window of opportunity to administer IV Zol, I don't think is justified. If you're going to measure it, then measure it early, before all of the fluid shifts associated with somebody who's acutely unwell. Can correction go ahead without vitamin D levels? Well, yes, I think it can, and that's demonstrated by the systematic review that I've presented, and up to 300,000 units seems reasonable based on the data presented in that systematic review. And if you're giving a higher dose, then you're more likely to suppress the PTH. Sorry for the timer. But ensure you check that somebody isn't hypercalcemic before you load them. And how quickly can vitamin D deficiency be corrected? Well, actually, with a high-dose regime, actually within a few days. I mean, if you give a loading dose on a Monday, you can actually measure a higher dose on the Tuesday. It goes up really quickly if you're measuring it serially day by day. And you don't need to repeat 25 OHD levels before or after replacement. So our expert consensus group statement says that many people with hip fracture have vitamin D deficiency. If vitamin D status is unknown and the serum calcium level is normal, any risks of empirical high-dose vitamin D loading are outweighed by the benefit of allowing IV Zol to be given promptly as an inpatient, and daily oral dosing regimes to provide 150 or 250,000 international units over 1 to 7 days are appropriate. That was our combined statement. And at this point, I'm going to hand over to our next speaker. You want to do questions now? Okay. Okay, thank you.
Lots of time for questions. There are questions. We know there are questions. 5 minutes.
Maybe I can ask a question. Can you put your hand up if you have access to routine vitamin D, or if you don't have access to routine vitamin D testing? Okay, so most people do, but that was about 10 hands, 11 hands perhaps. I would always replace, I'd give a loading which is oral. So I always use oral. D2IM doesn't work so well, variable bioavailability. So I would always use an oral dosing. And yes, I would load. I personally give up 300,000 international units. I split that into 6 doses, and I give them in sequential days so that I've then got time to give the IV Zol about a week later, which we'll come on to. Yeah, so I split the dosing.
Depends how long it
Yes, it does. Yes, and generally as a geriatrician you've got a feel for how long that patient might be in hospital because you know what their rehab needs are going to be, and so we replace the vitamin D according to how long we think they're going to be in hospital.
From what level would you give that loading dose, or how would you change the regimen according to that? Which means if it's 50 nanomol per liter, or 70 nanomol per liter, or 80 nanomol per liter, which are correct?
Yeah, so if you do have access to 25-OHD3 testing and you can get a test back that shows that your patient isn't deficient, then one doesn't need to load. But that is less common. I mean, more common is that you find deficiency. The point that I wanted to make based on that systematic review is even in the context where there is sufficiency, and then they loaded over and above that, you know, had you not known, then actually that proved safe and effective without AEs in that systematic review.
Will you give the same dose though?
Yeah. So yes, the same dose. If somebody's deficient, I give them 300,000 international units, and if I don't know, then I give them 300,000 international units. Yeah.
Thank you very much indeed. My name is Felix. I practice in the UK. Now, would you routinely do a FRAX score before you administer your Zol? Because if you put in the same data for different sexes, you will soon discover that for males, it scores very much less. And I think there is a release that if the score for the major fracture is less than 11%, in 10 years, you shouldn't administer treatment. What are your views?
Okay, so the question for those that couldn't hear, I think, was about the use of FRAX, and do I do that before I sort out their vitamin D and so on. So FRAX is a fracture risk assessment tool, and I think when somebody comes in with a fragility fracture of the hip, then they have a osteoporosis defining event, and they need some treatment in order to reduce their fracture risk. If they are a postmenopausal woman or a man over the age of 50, then actually irrespective of their FRAX score, which would be high, I will treat them. FRAX is not a complete stop-go. There's a lot of stuff in FRAX that isn't captured. It only asks 12 questions of a physician. It doesn't capture all of their clinical risk factors. Yes, you're right that it generally will find a lower probability in the context of men than women, but that wouldn't prevent me from giving anti-osteoporosis treatment for somebody who has had an osteoporotic fracture. If you look at the study by Eugene McCluskey looking at clodronate, he finds that the same fracture risk reduction is seen in people who have lower fracture probabilities. It's just that your absolute fracture risk is lower, and therefore your absolute risk reduction is lower, but the relative risk reduction is the same whether you have a high absolute risk or a low absolute risk.
Thank you. Hi, thank you for your talk. About giving zolidronate to all patients while they're still in hospital without doing a DEXA scan. Yesterday we were hearing that a lot of people develop a protocol where patients 70 or over are given IV zolidronate while they're still in hospital without a bone density test. So are you saying that we can do that for anyone who's over 50 then? Or?
Yeah, I mean, when somebody has fractured a hip, they have a very high imminent fracture risk. They're also unable to get onto a DEXA scanner for quite a lot of weeks. And our point is that one needs to get some treatment in promptly in order to reduce that very high imminent fracture risk. Now, that's not to say you shouldn't do a DEXA scan, and you may well do a DEXA scan if somebody is physically able to do that, and you need a baseline value in which to then compare a subsequent BMD after a course of IV Zol. Yeah, that's a good reason, but you don't need to do it immediately, and you certainly, I don't wait for a DEXA scan in order to give IV Zol to somebody who has had a fragility fracture of the hip, who has a high probability of refracture in the next 18 months.
Yeah, I've given several thousand people zoledronate after hip fracture over the last 15 years since they published the paper. I haven't done any vitamin D levels or FRAX scores, and all the DEXA scans are after zoledronate.
Last question. Yeah, sorry. Just want to ask about the age cutoff. So basically, you would give it for every single patient above 50 years old who had a hip fracture, they'll get IV zoledronate?
Not every single patient, because if somebody has had a fragility, it depends how they are physiologically, right? I mean, if somebody has had so NOG, the National Osteoporosis Guideline of the UK, says that IV Zol is a first-line osteoporosis treatment. In those people who come in with a hip fracture, if they have had a fragility fracture of the hip and they have lots of clinical risk factors for osteoporosis, then they're highly likely to have another fragility fracture at some point. In clinical practice, I have a conversation with that patient about what they actually want. Do they want IV Zol? Do they want to take an oral tablet, et cetera, et cetera? So actually, I'd have a conversation with the patient and find out what they want. Now, if the pathway is that they would like to have IV Zol, then I would give them IV Zol as a first-line treatment post-hip fracture, because that is the guideline. And as we heard already from Kaz, a lot of people who take alendronate don't take alendronate. It isn't necessarily... you can tell when you talk to a patient sometimes whether they're really going to stick to it or not. We don't actually see that many people in their 50s with a hip fracture. Our mean age is 82, so the majority of people over the age of 82, yes, we use a lot of Zol, providing their kidneys permit it.
We have time at the end to take some more questions, but I want to get through the report. So thank you very much, Celia.
Okay, thanks.